Welcome to the body imaging cases. Case 61 is a lesion that is most probably A. hepatocellular carcinoma, B. focal nodular hyperplasia. You are provided here with dynamic gadolinium enhanced MRI. The correct answer is focal nodular hyperplasia. Both hepatocellular carcinoma and focal nodular hyperplasia enhance strongly in the early phase of the dynamic gadolinium enhanced study. However, their washout features are slightly different. Focal nodular hyperplasia tends to wash out to hyperintensity or isointensity, as we see in this case, whereas hepatocellular carcinoma, as we will see in subsequent cases, washes out to hypointensity. The second differentiating point in this case is the presence of a central scar, not showing enhancement on the early phase of the dynamic gadolinium enhanced study and enhancing subsequently. The third difference is the absence of cirrhosis. As you see, this liver is not cirrhotic and the spleen is not enlarged, whereas hepatocellular carcinoma occurs most frequently in the cirrhotic liver. Case 62, this lesion is most probably a hepatocellular carcinoma, B. focal nodular hyperplasia, and again you are provided with dynamic gadolinium enhanced MRI. The correct answer in this case is hepatocellular carcinoma. The lesion enhances strongly on the first phase of the study and then washes out to hypointensity on the delayed image with enhancement of a pseudocapsule. The liver is cirrhotic and the spleen is enlarged, and we see portosystemic collaterals. We cannot discuss the diagnosis of hepatocellular carcinoma without discussion of the LIRADS classification system. This is a system of classification of liver lesions in the cirrhotic liver. LIRADS 1 and 2 are benign and probably benign lesions. LIRADS 3, 4, and 5 are hepatocellular carcinomas with different degrees of probability. LIRADS 3 is the least probable and LIRADS 5 is highly probable hepatocellular carcinoma. To simplify, we will follow 5 criteria allocated here to the 5 fingers of the hand. Number 1 is the size. Number 2 is the hyperintense enhancement, which means that the lesion is enhancing more than the liver on the early arterial phase of the dynamic gadolinium enhanced study or dynamic contrast enhanced CT. The third finger is washout, as we have seen in the previous case. The next criterion is the capsule, as we have also seen in the previous case, and the last is the increase in size if we happen to have more than one examination of the same patient and we notice an increase in size of the lesion. Now, if we put the threshold for the size as 20 millimeters, then we can diagnose the LIRADS 3 lesion by having any single finger. This means that if we are having a lesion more than 20 millimeter in the cirrhotic liver, without hyperintense enhancement, without washout, without a capsule, or without increase in size, then it is LIRADS 3. And similarly, if we are having a very small lesion, less than 20, with hyperintense enhancement, but no washout, no capsule, or no increase in size, then it is also LIRADS 3, and the same applies for the rest of the criteria. Let us put the size threshold now at 10 millimeter to diagnose a lesion as LIRADS 5. This diagnosis is very important because treatment is based on the radiological diagnosis of LIRADS 5 without verification by a biopsy. So to diagnose a lesion as LIRADS 5, we need to have the thumb and index plus any other finger. This means a lesion should be more than 10 millimeter, should have hyperintense enhancement on the early phase of the dynamic study, and then should have any of the other three criteria. Self-evidently, LIRADS 4 lies between the two simplifications. Applying this simplified approach of the LIRADS classification to the case we have just seen, this case shows early enhancement. It is more than 1 centimeter, just above the threshold of 1 centimeter, and it shows washout and it shows capsular enhancement. So it is a LIRADS 5 hepatocellular carcinoma. Case 63, this lesion is most probably metastasis, B, focal nodular hyperplasia, C, needs further assessment, and we are provided only with T2 weighted and T1 weighted MRI. The correct answer is that we need further assessment because we have overlapping features of metastasis and focal nodular hyperplasia. The lesion has what looks like a central scar. It is moderately hypointense to the liver on T1 weighted images and moderately hyperintense to the liver on T2 weighted images. This is the contrast enhanced study, and we see that the lesion is poorly enhancing in relation to the liver, and the enhancement is quite heterogeneous. So the diagnosis is metastasis. Enhancement pattern is a very important differentiating point between metastasis and focal nodular hyperplasia in case the unenhanced features overlap. Another method that may be helpful if we do not have the dynamic gadolinium enhanced study is the diffusion weighted image. And this is the diffusion weighted image of the same case we are discussing now, and it shows marked diffusion restriction at the periphery of the lesion, and this feature is a feature of metastasis and does not occur in focal nodular hyperplasia. If PET-CT is available, then this is also a way to differentiate between the two lesions. Metastasis will show uptake of the FDG, while focal nodular hyperplasia will not. In this case, we see also the uptake of FDG in the primary rectal carcinoma. Case 64, these lesions are classified as LIRADS 3, LIRADS 4, or LIRADS 5. You are provided with triphasic CT of the liver. This is a cirrhotic liver, and you see the lower esophageal varices, and the enhancing lesions are seen in the early phase of the triphasic CT. The correct answer is LIRADS 3. These lesions are showing only one finger, one criterion, as we have simplified the LIRADS classification, which is the hyperintense enhancement. They are smaller than 20 millimeters. They do not wash out. If we look at the delayed images, they do not have a capsule, and we have only one examination, so we cannot comment on the increase in size. So LIRADS 3 hepatocellular carcinoma. Case 65. This patient has hepatic steatosis, yes or no, and you are provided with out-of-phase T1 weighted MRI and in-phase T1 weighted MRI. And please note that the TE of the out-of-phase is less than that of the in-phase image. The correct answer is yes, and this is hepatic steatosis because there is drop of signal on the out-of-phase image in comparison to the corresponding in-phase T1 weighted image, which is taken at a higher TE. Case 66, this patient has hepatic steatosis, yes or no. You are provided with the same images like the previous case. The answer this time is no, because what you see here is the exact opposite of what we expect in hepatic steatosis. There is drop of signal on the in-phase images compared to the corresponding out-of-phase images. One more question about the case. Signal intensity decreases on the in-phase image here. A, because of its in-phase nature versus the out-of-phase image. And B, because of the increase in TE. And the correct answer is because of the increase in TE. This is a case of iron overload, and being in phase or out of phase doesn't play a role here. What is important is the increase in TE, because with the increase in TE, the susceptibility effect of the iron content increases, and therefore the drop happens on the image that is having a higher TE, which happens in the used protocol to be the in-phase image. One more question about the case. Iron overload in this patient occurs in A. hepatocytes, B. Kupffer cells. And the correct answer is Kupffer cells. Because if we look at the iron overload, it is not only in the liver. It is in the liver, in the spleen, and the bone marrow. And all of these are components of the reticuloendothelial system. And the representative of the reticuloendothelial system in the liver are the Kupffer cells and not the hepatocytes. Case 67. In this patient with hemolytic anemia, iron overload of the spleen exceeds that of the liver. True or false? We are provided here with MRI performed specifically for the quantification of the hepatic iron overload. We are having 4 different images with increasing TE. The TE of these images increase from 6 milliseconds to 9 milliseconds to 15 milliseconds and to 18 milliseconds in the 4th image. The correct answer is false. Signal intensity of the spleen is extremely low from the start, and unlike that of the liver, which shows decrease as we increase the TE compatible with iron overload, the spleen has a fixed signal intensity which is low from the start. The reason why this spleen is showing low signal intensity on the MRI is that because it is heavily calcified, and this happens in one type of hemolytic anemias, which is the sickle cell disease, because of the autosplenectomy or the multiple splenic infarctions followed by calcification. Iron overload in this patient is due to hemosiderosis or hemochromatosis. Again, we are provided with the same types of images, the out of phase and the in-phase T1 weighted MRI with higher TE on the in-phase images. The correct answer is hemochromatosis. Let us have a look at the distribution of the iron overload in this case. The liver is showing definite iron overload. It shows decrease in signal intensity on the higher TE image. The pancreas shows also significant iron overload, whereas the spleen and bone marrow are not showing iron overload. This means that it is not the reticuloendothelial system which is the site of the iron deposition here. And this is what happens, in fact, in hemochromatosis, which is a congenital error of iron metabolism in which the iron is stored in the liver, the cardiac muscle, the pancreas, and the articular cartilages more than in the reticuloendothelial system. Iron overload in this patient occurs in the hepatocytes or the Kupffer cells, and the answer is the hepatocytes. Cases 69 and 70. These are 2 different patients, and we are provided with contrast-enhanced CT, and it is sometimes a dilemma to diagnose fatty liver in the contrast-enhanced CT if we are not provided with the unenhanced images. Some radiologists will go directly to say that we cannot diagnose fatty liver in the contrast-enhanced CT, but let us look at some of the helpful signs to make this diagnosis. Which of these 2 patients has or have fatty liver? Case 69, case 70, both of them or none of them. And the correct answer is case 69, has hepatic steatosis. let us look at one of the helpful criteria for the diagnosis of fatty liver in the contrast-enhanced CT, which is the difference in the attenuation value on this contrast-enhanced CT between the intercostal muscles and the liver. If the attenuation value is more or less the same, like in case 69, then we most probably are having fatty liver. The normal situation is illustrated by case 70, where the contrast-enhanced liver has a definitely higher attenuation value than the intercostal muscles.